we have prepared a very interesting case, I think, to finish the session today. This is the fourth episode of MyStream 360. So we can see the slides. The first one, perfect. Next one. So she's an old lady, 82 years old, presenting with angina, dyspnea. She has a history of hypertension, dyslipidemia, a smoker. She also suffered from breast cancer. She was operated on and she received also radiotherapy on the chest. She also suffered from a carotid cavernous fistula associated with ophthalmic vein thrombosis, and that's why she received during some time oral anticoagulation. But any further treatment was necessary regarding that, but she is under follow-up with our neuroradiologist here. Next. So this is AGC, nothing special about that. The PQ is normal, some left deviation of the QRS axis. Next. So the blood test is quite normal renal function. Body mass index is 22. The echo Doppler showed a severe aortic stenosis with preserved left ventricular ejection fraction, 73. With gradients of 66 and 42, with an area of 0.6 square centimeters. According to the frailty evaluation by our team, she is not a frailty, she is not futile for this procedure. Next. So this is the regular angio that we always perform, as I told you before. She also has some vertebroplastia done there. This is the find that you can observe on the radioscopy there. This dark mark there on the lower part of the right coronary artery. Next. This is the left coronary artery, which is a vegan artery with huge vessels without any significant lesions, except probably some kind of breach on the middle segment of the LAD. Next. So this is a left caudal view showing that left main is perfect, no lesion on the ostium. The cranial view with similar findings, and once again, this not occlusive breach. Next. So according to the core lab evaluation on the CT scan, she has small annulus, 17 by 23, with a mean diameter of 20, with a perimeter area of 64, with an area of 320. So the coronary ostium height are 11 in this measurement for the left, and 11 something for the right. That's something that we are going to discuss later on. This is the sinus, which are also quite smaller, less than 30, 26 and 27. Next, the LVOT is also small. This is my evaluation here, or the evaluation that we always have in our team on the CT scan of every patient. Here in our findings, we can describe a significant calcification on the sinotemporal junction, as you observe, on the upper part of the left ostium, and also on the right. And below of the slide, we have measured the height of the coronary arteries, and the right coronary artery is not that high as 11, actually it's lower than 10. So it's at least on middle or high risk for coronary obstruction, because also the VTC distance that I calculated is also borderline, 3.8. So remember that 4 is okay, below 4 is high risk for coronary occlusion. The leaflets of the right is calcified, it's long, another issue to be considered about the protection of this coronary ostium. Next. This is the calcification on the stenotubular junction with this also small diameter, 21. This is important for the valve selection and also for the procedural, because we had to pull back the right catheter. Carlos, remember that?
Yes.
Before final deployment of the valve, because sometimes you have difficulties to retrieve the pigtail. Next. Here are the measurements done at the core lab, once again, 11 and 11. Next. And this is our angio-CT finding. Next. Next. and this is what I already told you, the BTC distance that I measured for the left and from the right, because you could ask me why not to protect the left, because it's also at 11 millimeters, and the right is a discussion between 11 and 9, which is my personal measurements. But here the BTC distance for the right is smaller, and as you can observe there, the distance from the estimated landing zone of the valve in comparison with the ostium of the left main is bigger. So that's why I think we are not risking the left, but yes, in a way we are, challenging or risking the right coronary ostium. Next. So this is the ascending aorta, also small aorta, significant calcification, but not that much. So that's why we have decided to go with direct implantation, not to pre-dilatation. Do you agree, Carlos, on that?
Yes,
Okay,
definitely.
Okay, perfect. Because this calcium is deep, I think it's not going to interfere with the valve dilatation and also not with the deployment. Next. So this is the aorta, not significant angulation, but not too low too. This is 50 degrees angulation according between the aortic annulus and the left ventricle. Next, no significant calcium on ascending aorta and also the aortic arc. Hopefully the vascular access are okay, a little bit of tortuosity on the right, but not that much, not too much calcium there. So maybe we can use the new technique that we are using is to use only one proglide. And then if we have bleeding, we can introduce an 8 French angioseal. Anyway, we are still doing for every single case the crossover for protection, especially when we are alive. Next. This is the aorta, and this is the diameters, good diameters. I think very good vascular access for this evolute implantation. Next. This is working projection. The LO could be LO 9 and caudal 8. And for the right, near to the cusp overlap is 5 right and caudal 26. But we have a different, that this is the angulation where we have a perfect cusp overlap view, which is right angulation 16 and caudal angulation of 35, 25. Okay, yeah. Perfect. So it's going to be in a very high caudal angulation. It's not going to be so comfortable for working. Next. So at the end, she's an octogenarian with severe coronary artery disease and aortic stenosis. Although the STS score is low due to the age and previous chest radiation, on the heart team discussion, the LAD PCI was suggesting and stage TAVI as a second procedure is where we are. Next. For some reason, we escaped the slide of the coronary angiography, but we can see probably in the next. So we did a LAD PCI by radial approach, and now we are prepared for femoral approach for this TAVI implantation with also right coronary ostium protection. For that reason, Dr. Carlos Fava has prepared radial approach that we'll show you later on. Next. Next. So this is the angio, where she has a moderate to severe lesion distally to this huge diagonal branch. We did a pre-dilatation and then a very short stent implantation. Next is something that probably we can discuss, but the patient has angina and his referral wanted that this lesion be treated. So we discuss about that. And this is the reason why we agree on doing that. And now we are here. So this is so the radial approach that Dr. Fava has already prepared, and on her left arm. Yes, if you turn to the right, we have a 6 French here, where we will introduce the right coronary artery guiding. We have femoral access here, arterial and venous. We are going to do crossover. We usually try to cross over with a pigtail. If something is not working, we prepare a seam as we did in the previous. Let me reshape the wire first, and then prepare vaso de cuello curva 2. Es SIM 2. Why would we change the catheter instead of the wire? Yeah, no, it's enough. Ya está. This reshape of the wire facilitate the crossover. Closing the loop of the wire is a good choice not to waste too much devices. So our salary can be increased. Here, aren't you guided? Here, perfect, correct? So here we have to make a small cut of the skin. We have to make a divulsion of the subcutaneous tissue to facilitate the prog-like thread movements. We are on SFA. We are going as deep as we can. Where we find some resistance, this is our place for parking. We retrieve the catheter, correct? Okay, leave the wire that we are using for protection and also for control of the closing. So we have chosen, according with the AKG that I showed to you, that is probably good patient for being patient with the wire, with the confida wire that we are going to use. And now I need the right coronary artery guiding. 1014 extra support. O el guiding de derecha y la extra support. Right is normal. We will leave an extra support wire there. And remember, as always, we usually do this kind of maneuver. We will put a guide extension inside. In case we have a problem, we will introduce the stent through this guide extension. So with this maneuver, we prevent to destroy the stent if it is not necessary. Okay, now we will try to cross with our regular maneuver with the shear wire. If we have problems, we will try with the Amplatz catheter and then to change with another, with the pigtail, sorry. On this view, I try to be sure that the wire is distal enough, not entangled with the wires, excuse me, the cords of the mitral valve. So I think this position, it's okay. Now I'm going to positioning the pigtail for control during delivery. Now that everything is in place, we have a clean area. We can pull the wire. We can close it. We can measure the gradient. Give me a second, flash. Okay. Now you can measure the gradient, which is like 80. And you see that the right coronary ostium on the middle part of the monitor is not that high. So I think it's important to protect it. So we will shape the wire while Tim is preparing the valve until the valve is ready. When the valve is ready, we will check it. Now we are going to introduce the wire and we are going to the working position. Okay, and now we are going with the direct implantation. To have better support and to positioning the guide extension a little bit distally. I know I'm going to produce a little bit ischemia, but it's better because during deployment, if we have to retrieve the valve, you have repositioning, we might lose the position and everything, all our work will be lost. So I am advancing a balloon distal enough to have a better support and probably advance the axilla a little. In this case, it's a Medtronic device. It's not that easy. Yeah? Let me go distally with the balloon. If not, we have to accept that this is the best position we can reach. Now it's much, much better. Okay. And we can start deployment there. I think the position is okay. Let's go to the LV view. Here it's important to see also the right coronary artery. We have to check in advance, inyectar. Dale, Carlitos. Position is okay. Okay. Perfect. Okay. Well, very complex also. Let me see what's going on here. Basta de llenarlo, que lo tenés lleno. Position is okay. Stay there, quédate ahí. So now I'm sure that both pedals are free. I centralize with my shaping wire the nose cone and I retrieve it. We are closing without too much overlapping the device. Well, this is a very nice point to be discussed. With the self-expandable valve, the benefit is you can repositioning, you can go a little bit deeper, you can check it before final delivery. But if you are going high, like we go with the cathode view, we are risking a little bit more. The benefit of balloon expandable is the frame of the stem is shorter. The upper crown of the balloon expandable valve are higher and probably easier for coronary access, especially in young patients. So it's something that should be considered in this patient if we are probably a 60 or 70 or something like this, and for some reason you are doing TAVI instead of surgery. This is something important. But here, with an 80 years old lady, I think this is not important. But anyway, it's an important question. And this is the final release. So now we are going to close here. We are pull here. We show you. Of course, the case is done.